Professor Shanti Parikh, Professor of Sociocultural Anthropology and of African and African American Studies at Washington University in St. Louis, and Dr. Paulo Dalgalarrondo, Professor of Psychiatry at the University of Campinas in Brazil. They will jointly present on their collaborative work on the impact of COVID-19 pandemic on HIV care in Campinas, Brazil, and in St. Louis, USA. Over to you, Shanti and Paulo.
So as Bill has mentioned, this is a collaborative study between St. Louis and Brazil. And I'm actually extremely excited to hear George's work in Ghana, because when we both got these grants, we thought this would be great for the 3 sites to collaborate. So a lot of our questions that were guiding our research were very similar. So I just first want to acknowledge the team. On our side at WashU, the principal investigator, and then we also have other people from the research team. And I'd also like to highlight Elvin Gang, who helped conceptualize this from the beginning. And then he and Dr. Mahdi both got very busy, so they were involved in the earlier stages. But I want to recognize the WashU team. And then anything on the Brazil side, Paulo? Our questions were very similar to what George presented, so I'll go through these quickly. We were particularly curious about the impact that the COVID pandemic, and particularly the close downs, the social distancing, the difficulty in transportation, how that impacted patients' engagement with care. And when we say engagement with care, we were interested in both clinical outcomes at particular points, both before the pandemic and at particular points during the pandemic. And now that the pandemic is a lot longer, we're still monitoring that. And similar to George's, perceptions of patients and providers in terms of the perceptions and experiences with care and support, and what we're calling non-clinical life projects. So things that don't have to do with their HIV, but might, of course, be influential in shaping their lives. In terms of data, we were interested in the analysis of clinical data, both before the pandemic as sort of a snapshot of quote unquote normalcy, and then at different points during the pandemic. And for qualitative interviews, they were case managers, also doctors, other providers, and primarily people living with HIV. And we were interested in sort of comparing what the clinical outcomes were telling us in addition to what the narrative were telling us. And Paulo, if you want to jump in at any time, please feel free.
Okay, thank you.
I'll start with the clinical outcome. And this was actually a nice surprise for both Brazil and St. Louis. Much of this research we did separately, and we would come together to compare. The clinical data in St. Louis showed that there was very little change to clinical outcomes in HIV indicators. So from the beginning of the pandemic, we're taking 2019 as pre-pandemic because most of the data was from pre-pandemic, and then 2020, we're considering that the pandemic. So as you can see, viral suppression was, and again, these are people who are attending the WashU infectious disease clinic. So before the pandemic, we had a great viral suppression rate. It went slightly up during the pandemic, but it wasn't significant. It wasn't statistically significant. And in terms of the undetectable, same. It was very impressive before the pandemic, a very slight, statistically insignificant increase. Retention of visits is an indicator that we use in the US, and that is what percentage of people retain their office visits, 72% before, and a slight increase afterwards that is only slightly significant. We had thought we would see, so this is the telehealth visits. These are the people who did not keep. So we only had 18% who kept their telehealth visits. And when we started the project, I think both sides were thinking that telehealth, ranging from the phone to Zoom, would actually provide a very promising area. We still think it does, what this might indicate is that early on, I think as George said, stigma, systems weren't in place, providers, case managers. So I think there's a great opportunity here. We were just thinking that it would be greater. And the days between visits reduced slightly. In terms of the Campinas data, and Paulo, if you want to jump in, feel free. I'll just quickly go through this. They found the same thing, that there was little impact on viral suppression in the context, but their context is slightly different. They have a national database, so they were able to pull both from the national database as well as the pharmacy. They also have universal access to antiretrovirals, whereas the data that we presented is, I guess both, is only really catching the people who are receiving care. So these numbers, how they, something we also found out from this project, which was really useful, is where we could compare data, because data in the United States and Brazil is collected very differently. So they measure success based on if people are coming in to receive their antiretrovirals every 30 days, and then there's a cushion just in case people have leftovers. So before the pandemic, if we could consider February before the pandemic, it was about 80%. And then December, it was 84%. And let's see, what else from this slide? People, this is considered people who might have, in the United States, we might call it falling out of care, or people who didn't return to pick up their medicine. So that actually, it's not statistically significant, but might have, by these numbers, looks like it might have decreased. And then these are particularly important figures because these are people who are not doing well on HIV or defined in delay. So all of this to say both sets were a surprise to us because it remained stable, if a slight, not significant statistical increase. So we actually started the interviews before we compiled the data, at least on the US side, just because of timing when data was released. So as we went into our qualitative interviews, we kept finding the same, people saying their HIV care remained the same. And we were anticipating the clinical data because we wanted to see if this bore out in the clinical data, and indeed it did. So what did we find? So in terms of St. Louis, we indeed did find qualitatively, people felt when we said, how is your HIV care? How has your been able to accessing things been affected? Most people say not greatly, but they did perceive there were other negative impacts on wellness. And we're saying wellness, it also includes comorbidity. So that was the interesting dynamic. So case managers tended to focus on clients who were more vulnerable. So all of this is a great plus to our HIV system in the US, but I think also in Brazil is, and maybe there, I think all of us who work on other health issues think that there are some lessons that can be learned by the way we have tackled, say, HIV or other health conditions. People were interested in the flexibility of telehealth, but they found it difficult for a lot of the reasons George mentioned: stigma, access. There was difficulty in knowing where to go when you were on telehealth because people were inside, they didn't have a lot of privacy, or they just weren't familiar with the technology. And we have a quote from a patient, a gay white rural resident. It was right when the pandemic started, and I think I was feeling good. Instead of canceling the appointment, we just did telehealth. So a lot of clients did say they appreciated that telehealth was there. They found it a big benefit. We didn't find a lot who used it, but that indicates, again, an opportunity for getting maybe harder to reach populations into HIV care, into COVID care. And he continues, I'm old school, I don't know. In my mind, I can't figure out what they can do until how. You know what I mean, how much good it can do. So there was a culture, and he's 53, there's a culture of care as being a more intimate, in-person practice. And that is indeed what we found. So people, what we did find also is people who were living with HIV, it was easier for them to understand the need to take precaution with COVID. whereas they perceived that people around them might have been hesitant or skeptical, or even on the more extreme denying or extremely hesitant. For them, the idea that they needed to take better precautions, the idea of the immune system, was something that we found that they had a greater respect and appreciation for. But as a result, they also did find that they had difficulties with some of their pre-existing health conditions. So in our interviews, we would talk about HIV and they would talk about diabetes, or they would talk about hypertension or weight gain. That was a common theme that also for older patients. Loneliness was a huge issue that kept occurring. And that was one of the reasons people said they wanted to do office visits. They said, and as you saw, there was a slight uptick in the percentage of people who kept their office visits, but also a reduction in days. And we found that going in person to see their case manager or to see the doctor was a positive. It was a way for them to have intimate contact with people. We also found that there was some mental health issues. So all of this is preliminary. We have a lot of analysis that we need to do. I think George covered some of the obstacles we were going to talk about, which is transportation, getting there. I will now slip over to, I'm going to let Paulo, if you're able to, Paulo, if you want to explain some of your findings.
Yes, Shanti. Well, we in the qualitative side of the research, we had already interviewed 55 patients. Most are men, but we have a significant number of women also, as the epidemics, the HIV epidemics in Brazil. We have a lot of women also, not so as in the US, that the prevalence of men are much higher. Huh? And Afro-Brazilians are the majority here, and also a slight majority are receiving government economic aid. They are the poorest people from this group. This group belongs to a public service in Brazil, the National Universal Health Service, the SUS in Brazil, and most are patients that come from the poor groups. Huh? Before and after the pandemics, in this group, we did not find differences about viral loads. Viral loads around the same. And in our group, we found from the 55, 8 patients that have serious problems with treatment adhesion, treatment commitment, that are not taking the drugs from the pharmacy, and what surprised us that all of these 8 people in this group, all 8 were women and Afro-Brazilians, and most receiving government economic aid. Well, then the idea, we have just preliminary ideas, preliminary interpretations of these first 55 interviews, is that treatment non-commitment, non-adherence might be associated here with poverty, racial discrimination that people talk about to us in the interviews, and also this group has more alcohol and drug abuse, and depression and anxiety are surprised in all the interviews how high level of depressive symptoms or depressive experiences and anxiety in this group. In this, the general ideas, it seems to have increased during the pandemic as loneliness, as Shanti told now. Then it's similar, the experience well, we have particular special questions, issues here in Brazil.
So in terms of next steps, we would, sorry, Paulo, the reception was going out. In terms of next steps, we're going to continue the country-based analysis, but we would also like to do more cross-country analysis, particularly on the qualitative data and getting some updated clinical data. The teams have talked about doing a joint in-person analysis and dissemination because some of the people on their side speak only Portuguese. And of course, on our side, we speak no Portuguese. So, so that would help facilitate it. But I'll stop there, Bill, because I know we are running out of time. We still think there's a good opportunity.